Question 1. A critical care nurse is managing a patient with a severe subarachnoid hemorrhage. Which medication regimen would the nurse anticipate to prevent vasospasm? A. For nicardipine drip to maintain mean arterial pressure between 70 to 80 millimeters of mercury. B. Oral nimodipine 60 milligrams every 4 hours. C. Intravenous labetalol to keep systolic blood pressure less than 160 millimeters of mercury. D. Subcutaneous enoxaparin for deep vein thrombosis prophylaxis. Answer B. Oral nimodipine 60 milligrams every 4 hours. This question tests knowledge of subarachnoid hemorrhage, SAH, management, specifically the prevention of cerebral vasospasm. The keyword vasospasm in an SAH patient immediately points to nimodipine, a calcium channel blocker, as the primary prophylactic treatment. Nimodipine is given orally or via nasogastric tube to reduce the incidence and severity of neurological deficits caused by vasospasm, not to control blood pressure generally. For example, if a patient admitted with a ruptured aneurysm begins to show new neurological deficits days later, vasospasm is suspected, and nimodipine therapy would be a key part of their care plan. Always remember that nimodipine is specific for preventing and managing vasospasm after SAH. Question 2. A patient admitted with a severe traumatic brain injury, TBI, has a Glasgow Coma Scale, GCS, score of 6. The nurse notes decorticate posturing when noxious stimuli are applied. This finding indicates injury to which area of the brain? A. Brainstem. B. Cerebral hemispheres. C. Cerebellum. D. Spinal cord. Answer B. Cerebral hemispheres. This question assesses understanding of neurological posturing and its anatomical correlation with brain injury. The key term decorticate posturing points to damage above the midbrain, specifically within the cerebral hemispheres or the internal capsule. Decorticate posturing, characterized by adduction and flexion of the arms, flexion of the wrists and fingers, and extension and internal rotation of the legs, occurs when there is damage to the corticospinal tracts above the red nucleus. For example, a patient with a large supratentorial hemorrhage might exhibit decorticate posturing. Remember that decorticate posturing suggests significant damage to the cerebral hemispheres, while decerebrate posturing indicates more severe damage lower in the brainstem. Question 3. A patient with a ventriculostomy drain for elevated intracranial pressure, ICP, suddenly develops a headache, fever, and neck stiffness. The nurse notes the cerebrospinal fluid, CSF, draining from the ventriculostomy appears cloudy. What is the most likely complication occurring? A. Cerebral vasospasm. B. Hydrocephalus. C. Ventriculostomy-associated infection. D. Rebound intracranial hypertension. Answer C. Ventriculostomy-associated infection. This question evaluates the nurse's ability to recognize signs of a common complication associated with invasive neuromonitoring devices. The keywords headache, fever, neck stiffness, combined with cloudy CSF draining from a ventriculostomy, are classic indicators of a central nervous system infection, specifically ventriculostomy-associated meningitis or ventriculitis. Cerebral vasospasm is typically a complication of subarachnoid hemorrhage and presents with delayed neurological deficits, not fever. For instance, if these signs appear in a patient with an external ventricular drain, immediate CSF culture and antibiotic initiation would be critical. Always suspect infection when a patient with an invasive CNS device develops systemic signs of infection and changes in CSF appearance. Question 4. A patient with a C5 spinal cord injury is experiencing a sudden, severe pounding headache, diaphoresis above the level of injury, and a blood pressure of 200/110 mmHg. The nurse identifies these findings as indicative of which life-threatening condition? A. Neurogenic shock. B. Autonomic dysreflexia. C. Spinal shock. D. Orthostatic hypotension. Answer B. Autonomic dysreflexia. This question tests recognition of a critical complication specific to spinal cord injuries above T6. The keywords sudden, severe pounding headache, diaphoresis above the level of injury, and blood pressure of 200/110 mmHg in a patient with a C5 spinal cord injury are hallmark signs of autonomic dysreflexia. This is a medical emergency caused by an exaggerated sympathetic response to noxious stimuli below the level of injury, such as a full bladder or bowel. Neurogenic shock presents with hypotension and bradycardia, while spinal shock is characterized by flaccid paralysis and loss of reflexes. For example, checking for a distended bladder or impacted bowel is the immediate priority in such a patient. Remember, autonomic dysreflexia is a hypertensive crisis that requires prompt identification and removal of the trigger. Question 5. A nurse is caring for a patient admitted with an ischemic stroke who received tissue plasminogen activator, tPA, 4 hours ago. Which finding would be the most concerning and require immediate notification of the healthcare provider? A. Blood pressure of 150/90 mmHg. B. Generalized headache and sudden onset of left-sided weakness. C. Persistent mild nausea. D. New onset of ecchymosis at the fore-insertion site. Answer B. Generalized headache and sudden onset of left-sided weakness. This question focuses on recognizing signs of a critical complication following thrombolytic therapy for ischemic stroke. The keywords tPA 4 hours ago and most concerning require the nurse to identify signs of intracranial hemorrhage, a major risk of tPA. A generalized headache and sudden onset of left-sided weakness represents new or worsening neurological deficits, which are red flags for intracranial bleeding. While mild nausea or ecchymosis are concerning, new neurological changes are far more critical. For instance, a patient developing these symptoms post-tPA would need an immediate CT scan to rule out hemorrhage. Always prioritize new neurological deficits after tPA, as they often indicate a life-threatening bleed. Question 6. The nurse is preparing to admit a patient from the emergency department diagnosed with bacterial meningitis. Which isolation precautions should the nurse implement upon the patient's arrival? A. Contact precautions. B. Droplet precautions. C. Airborne precautions. D. Standard precautions only. Answer B. Droplet precautions. This question assesses the nurse's knowledge of infection control protocols for specific neurological conditions. The keyword bacterial meningitis indicates a condition where pathogens can be spread through respiratory droplets. Therefore, droplet precautions are necessary, which include wearing a surgical mask when within 3 feet of the patient, in addition to standard precautions. Contact precautions are for direct or indirect contact spread, and airborne precautions are for very small particles that can remain suspended in the air. For example, if a patient is diagnosed with meningococcal meningitis, droplet precautions are crucial to prevent transmission to healthcare workers and other patients. Always remember that droplet precautions are essential for bacterial meningitis, especially during the initial contagious period. Question 7. A patient sustained a severe head injury and is now exhibiting Cushing's triad. Which set of vital signs is consistent with this finding? A. Blood pressure 90/50 mmHg, heart rate 120 bpm, respiratory rate 24. B. Blood pressure 160/70 mmHg, heart rate 50 bpm, irregular respirations. C. Blood pressure 120/80 mmHg, heart rate 80 bpm, respiratory rate 16. D. Blood pressure 80/40 mm of mercury, heart rate 150 bpm, Cheyne-Stokes respirations. Answer B. Blood pressure 160/70 mmHg, heart rate 50 bpm, irregular respirations. This question tests the understanding of Cushing's triad, a critical sign of increased intracranial pressure, ICP, and impending brain herniation. The keywords Cushing's triad refer to the classic clinical presentation of severe hypertension, widening pulse pressure, bradycardia, and irregular respirations. These signs indicate significant brainstem compression. Option B accurately reflects these three components: elevated systolic BP with a low diastolic, widening pulse pressure, a slow heart rate, and an irregular respiratory pattern. For instance, if a TBI patient's ICP continues to rise despite interventions, these vital sign changes would signal a neurological emergency. Recognizing Cushing's triad is vital as it signifies a late, ominous sign of increasing ICP. Question 8. The nurse is monitoring a patient with an external ventricular drain, EVD, set to drain at 10 cm H2O. The nurse notes continuous drainage of 20 to 30 ml/hour and an ICP of 18 mm of mercury. What is the most appropriate initial nursing action? A. Increase the drainage height of the EVD to 15 cm H2O. B. Notify the physician immediately as the ICP is too high. C. Document the findings and continue to monitor. D. Lower the drainage height of the EVD to 5 cm H2O. Answer C. Document the findings and continue to monitor. This question assesses the nurse's understanding of normal EVD function and ICP parameters. The keywords EVD set to drain at 10 cm H2O, continuous drainage of 20 to 30 ml/hour, and ICP of 18 mm of mercury are crucial clues. An ICP of 18 mm of mercury is within the acceptable range, typically below 20 to 22 mm of mercury, and CSF drainage of 20 to 30 ml/hour is also within expected limits for an EVD. There are no immediate signs of concern requiring alteration of the EVD or physician notification. For example, if the ICP were consistently above 20 mm of mercury despite adequate drainage, then an intervention would be necessary. Always interpret EVD readings within the context of established parameters and the patient's clinical picture. Question 9. A patient with myasthenia gravis is admitted to the ICU experiencing increasing muscle weakness, dyspnea, and difficulty swallowing. The nurse suspects a myasthenic crisis. Which intervention is the most immediate priority? A. Administering a bolus of intravenous fluids. B. Preparing for intubation and mechanical ventilation. C. Initiating a plasma exchange. D. Administering a pyridostigmine dose. Answer B. Preparing for intubation and mechanical ventilation. This question tests the nurse's prioritization in a life-threatening neurological crisis. The keywords myasthenic crisis, increasing muscle weakness, dyspnea, and difficulty swallowing clearly point to impending respiratory failure, which is the most immediate threat to life. While plasma exchange and pyridostigmine are treatments for myasthenia gravis, stabilizing the patient's airway and breathing takes precedence during a crisis. For instance, a patient unable to clear secretions or maintain adequate oxygenation requires immediate airway support. Always prioritize airway and breathing interventions in any acute neurological or respiratory crisis. Question 10. The nurse is assessing the pupillary response of a patient with a suspected brain herniation. The nurse notes the left pupil is fixed and dilated, while the right pupil is 3 mm and reactive to light. This finding indicates compression of which cranial nerve? A. Cranial nerve 2, optic C. B. Cranial nerve 3, oculomotor. C. Cranial nerve 4, trochlear. D. Cranial nerve 6, abducens. Answer B. Cranial nerve 3, oculomotor. This question assesses the nurse's ability to localize neurological deficits, specifically pupillary changes, to a particular cranial nerve. The keyword fixed and dilated pupil in the context of brain herniation is a classic sign of compression of the ipsilateral cranial nerve 3, the oculomotor nerve. The oculomotor nerve is responsible for pupillary constriction, and its compression results in a dilated, non-reactive pupil on the same side as the injury. Cranial nerve 2 is for vision, and cranial nerves 4 and 6 primarily control eye movement, not pupillary light reflex. For example, if a patient with a rapidly expanding epidural hematoma on the left side develops a left fixed and dilated pupil, it indicates significant ipsilateral CN3 compression. Recognizing this specific pupillary change is crucial for identifying an urgent neurological emergency. Question 11. A patient with a severe head injury is receiving hypertonic saline infusions to manage increased intracranial pressure, ICP. The nurse understands that the primary mechanism of action for hypertonic saline is to A. Decrease cerebral blood flow. B. Increase capillary permeability in the brain. C. Create an osmotic gradient to draw fluid from brain cells. D. Promote diuresis and reduce overall fluid volume. Answer C. Create an osmotic gradient to draw fluid from brain cells. This question explores the pharmacological principles behind managing increased ICP. The keyword hypertonic saline as a treatment for increased intracranial pressure points to its osmotic effect. Hypertonic saline works by creating an osmotic gradient between the blood and the brain tissue, drawing excess fluid out of the swollen brain cells and into the intravascular space, thereby reducing cerebral edema and ICP. While it does eventually lead to some diuresis, its primary and immediate effect on ICP is through this osmotic shift. For example, a patient with a large cerebral contusion might receive a bolus of 3% saline to acutely reduce brain swelling. Remember that hypertonic saline directly reduces brain swelling by pulling water out of the cells. Question 12. A critical care nurse is assessing a patient with a suspected basal skull fracture. Which finding is most indicative of this type of injury? A. Periorbital ecchymosis, raccoon eyes. B. Positive Babinski reflex. C. Unilateral pupillary dilation. D. Decerebrate posturing. Answer A. Periorbital ecchymosis, raccoon eyes. This question tests the nurse's knowledge of specific clinical signs associated with different types of head injuries. The keywords basal skull fracture and most indicative require recognition of the characteristic signs that point to a fracture at the base of the skull. Periorbital ecchymosis, also known as raccoon eyes, results from bleeding into the periorbital tissues, indicating extravasation of blood from a basal skull fracture. Other signs include Battle's sign, postauricular ecchymosis, and CSF rhinorrhea or otorrhea. For example, a patient who fell and hit their head and then develops bruising around both eyes without direct eye trauma should be suspected of having a basal skull fracture. Always remember that raccoon eyes are a key indicator of a basal skull fracture. Question 13. The nurse is caring for a patient admitted with a severe hemorrhagic stroke. The patient suddenly becomes unresponsive, develops fixed and dilated pupils, and demonstrates decerebrate posturing. The nurse should immediately prepare for which intervention? A. Administration of osmotic diuretics. B. Emergent surgical decompression. C. Administration of intravenous mannitol. D. Initiation of therapeutic hypothermia. Answer B. Emergent surgical decompression. This question tests the nurse's ability to recognize signs of acute neurological deterioration requiring immediate, definitive intervention. The keywords unresponsive, fixed and dilated pupils, and decerebrate posturing in a patient with a severe hemorrhagic stroke signify severe, rapidly increasing intracranial pressure, ICP, with brainstem compression and herniation. These are signs of imminent brain death if not reversed. While mannitol and osmotic diuretics might be used, in this acute, severe scenario, emergent surgical decompression, for example, craniotomy, to evacuate the hematoma is the most direct and potentially life-saving intervention. For instance, a patient with a rapidly expanding hematoma exhibiting these signs needs to go to the operating room immediately. Always understand that rapid deterioration with fixed pupils and decerebrate posturing often necessitates urgent surgical intervention. Question 14. A patient with a GCS of 7 is receiving continuous force sedation. The nurse needs to perform a thorough neurological assessment. What is the most appropriate action prior to the assessment? A. Administer a paralytic agent to improve motor assessment. B. Temporarily pause the sedative infusion and allow the patient to awaken slightly. C. Increase the sedative infusion to ensure patient comfort. D. Perform the assessment without altering the sedative dose. Answer B. Temporarily pause the sedative infusion and allow the patient to awaken slightly. This question addresses a critical aspect of neurological assessment in sedated patients. The keyword GCS of 7 indicates significant neurological impairment, and continuous force sedation highlights a potential confounder in assessment. To accurately assess a patient's neurological status, especially their GCS and motor responses, the nurse must temporarily reduce or pause the sedative infusion to allow the patient to lighten their level of consciousness, as sedation significantly impacts GCS scores. Administering paralytics would hinder, not improve, motor assessment. For example, a patient on propofol would need their infusion held for several minutes before their true neurological baseline could be accurately determined. Always remember to assess neurostatus at the patient's lightest possible level of sedation. Question 15. The nurse is caring for a patient post-craniotomy for a brain tumor. Which finding requires immediate intervention? A. Temperature of 38, 5 degrees C, 101, 3 degree F. B. Urine output of 150 milliliters in 4 hours. C. Clear dressing over the incision site. D. New onset of slurred speech and weakness on one side. Answer D. New onset of slurred speech and weakness on one side. This question evaluates the nurse's ability to prioritize complications in a post-craniotomy patient. The keywords post-craniotomy and immediate intervention demand identification of a new neurological deficit, which is a critical concern. New onset of slurred speech and weakness on one side strongly suggests a developing stroke, hematoma, or cerebral edema, indicating a neurological emergency that requires urgent assessment and intervention. While a fever needs attention, and urine output should be monitored, new neurological deficits are much more immediately threatening to brain function. For instance, If a patient who was previously neurologically intact after surgery suddenly develops these symptoms, an immediate CT scan and physician notification are essential. Always prioritize new neurological changes in post-craniotomy patients, as they can indicate life-threatening complications. Question 16. A patient with a severe stroke develops diabetes insipidus. Which laboratory finding would the nurse anticipate? A. Serum sodium 125 milliequivalent/L. B. Urine specific gravity 1,030. C. Serum osmolality 310 mosm/kg. D. Decreased urine output. Answer: C. Serum osmolality 310 mosm/kg. This question tests understanding of diabetes insipidus, DI, a common endocrine complication in neurocritical care. The keywords diabetes insipidus indicate a deficiency in antidiuretic hormone, ADH, leading to excessive water loss. This causes hypernatremia, high serum sodium, and high serum osmolality due to hemoconcentration, along with low urine-specific gravity and increased urine output. A serum osmolality of 310 mosm/kg is elevated and consistent with the body trying to conserve water in the absence of ADH. For example, a patient post-tPA with copious dilute urine and rising serum sodium would likely be diagnosed with DI. Remember, DI is characterized by polyuria, excessive urination, of dilute urine and hypernatremia. Question 17. The nurse is performing a neurological assessment on a patient suspected of having an epidural hematoma. Which pattern of consciousness change is classic for this type of injury? A. Gradual deterioration of consciousness over several days. B. Rapid onset of coma immediately after injury. C. Brief loss of consciousness followed by a lucid interval, then rapid deterioration. D. Fluctuating levels of consciousness with no clear pattern. Answer: C. Brief loss of consciousness followed by a lucid interval, then rapid deterioration. This question assesses knowledge of specific injury patterns in traumatic brain injury. The keywords epidural hematoma and classic for this type of injury point to the characteristic presentation of a lucid interval. An epidural hematoma typically results from arterial bleeding, causing a rapid accumulation of blood. This often presents as an initial brief loss of consciousness, followed by a period of apparent alertness, the lucid interval, and then a rapid and severe neurological deterioration as the hematoma expands and compresses the brain. For example, a patient hit in the head might seem fine for an hour or two before suddenly collapsing. Recognizing this specific pattern is crucial for early diagnosis and intervention. Question 18. A critical care nurse is managing a patient on mechanical ventilation following a severe TBI. The ventilator settings include a respiratory rate of 20 breaths/min. The arterial blood gas, ABG, results show PaCO2 of 30 mm of mercury. What adjustment might be considered to help manage ICP? A. Decrease the respiratory rate to 12 breaths/min. B. Increase the PEEP setting. C. Maintain the current respiratory rate. D. Increase the respiratory rate to 25 breaths/min. Answer: C. Maintain the current respiratory rate. This question tests the nurse's understanding of ventilation strategies for ICP management. The keywords PaCO2 of 30 mm of mercury in a severe TBI patient are central. Mild hyperventilation to maintain a PaCO2 between 30 to 35 mm of mercury can cause cerebral vasoconstriction, which helps reduce cerebral blood volume and, consequently, intracranial pressure, ICP. A PaCO2 of 30 mm of mercury is already within this therapeutic range. Further increasing the respiratory rate, to lower PaCO2 even more, could lead to excessive vasoconstriction, resulting in cerebral ischemia. Therefore, maintaining the current respiratory rate is appropriate. For instance, if the PaCO2 were 45 millimeters of mercury, then increasing the respiratory rate to bring it down to 30 to 35 millimeters of mercury would be warranted. Always remember that extreme hyperventilation, PaCO2 less than 25 millimeters of mercury, is generally avoided due to the risk of cerebral ischemia. Question 19. A patient with a traumatic brain injury has an intracranial pressure, ICP, of 25 millimeters of mercury and a mean arterial pressure, MAP, of 80 millimeters of mercury. What is the patient's cerebral perfusion pressure, CPP, and what is its clinical significance? A. CPP 55 millimeters of mercury indicates adequate brain perfusion. B. CPP 55 millimeters of mercury indicates critically low brain perfusion. C. CPP 105 millimeters of mercury indicates adequate brain perfusion. D. CPP 105 millimeters of mercury indicates critically high brain perfusion. Answer B. CPP 55 millimeters of mercury indicates critically low brain perfusion. This question assesses the nurse's ability to calculate cerebral perfusion pressure, CPP, and interpret its significance. The keywords ICP of 25 millimeters of mercury and MAP of 80 millimeters of mercury require calculation using the formula CPP equals MAP ICP. In this case, CPP equals 80, 25 is equal to 55 mmHg. A CPP below 60 millimeters of mercury is generally considered critically low and indicates inadequate brain perfusion, increasing the risk of secondary brain injury. For example, a CPP below this threshold often prompts interventions to increase MAP or decrease ICP. Always remember that maintaining a CPP greater than 60 to 70 millimeters of mercury is a critical goal in managing severe TBI to ensure adequate blood flow to the brain. Question 20. The nurse is caring for a patient who suffered a stroke involving the right cerebral hemisphere. Which clinical manifestation would the nurse most likely expect to observe? A. Expressive aphasia. B. Left-sided neglect. C. Right-sided weakness. D. Difficulty with mathematical calculations. Answer B. Left-sided neglect. This question tests the nurse's understanding of hemispheric specialization and stroke manifestations. The keyword right cerebral hemisphere points to functions primarily localized to that side of the brain. The right hemisphere is often associated with spatial awareness, perception, and attention to the left side of the body and environment. Therefore, left-sided neglect, where the patient ignores the left side of their body or visual field, is a classic manifestation of a right hemisphere stroke. Expressive aphasia and difficulty with mathematical calculations are typically associated with left hemisphere damage, and right-sided weakness would be expected with a left hemisphere stroke. For example, a patient might ignore food on the left side of their plate or bump into objects on their left. Always remember that damage to one side of the brain typically causes deficits on the opposite side of the body, but neglect syndrome is specific to the right hemisphere and the contralateral, left, side. Question 21. A patient with a history of recurrent seizures is admitted with status epilepticus. What is the most appropriate initial medication to administer? A. Phenytoin. B. Levetiracetam. C. Lorazepam. D. Phenobarbital. Answer C. Lorazepam. This question tests immediate pharmacological management of a neurological emergency. The keyword status epilepticus signifies a medical emergency requiring rapid intervention to stop continuous seizure activity. Benzodiazepines, such as lorazepam, Ativan, or diazepam, Valium, are the first-line medications for status epilepticus due to their rapid onset of action in aborting seizures. While phenytoin, levetiracetam, and phenobarbital are often used as maintenance or second-line anticonvulsants, they are not the initial choice for immediate seizure cessation in status epilepticus. For instance, in the ER, lorazepam is quickly administered to stop the ongoing seizure activity. Always remember that benzodiazepines are the immediate go-to for acute seizure cessation in status epilepticus. Question 22. The nurse is performing a doll's eye, oculocephalic reflex, maneuver on an unconscious patient. The nurse quickly turns the patient's head to the right, and the eyes remain fixed, moving with the head. This finding indicates A. An intact brainstem reflex. B. A positive oculocephalic reflex. C. Absence of brainstem function. D. Normal response in an unconscious patient. Answer: C. Absence of brainstem function. This question assesses the nurse's understanding of brainstem reflexes and their interpretation in neurological assessment. The keywords unconscious patient and eyes remain fixed, moving with the head when performing the doll's eye maneuver indicate an absent oculocephalic reflex. A normal or positive doll's eye reflex would be for the eyes to move conjugately to the opposite direction of the head turn. For example, turn head right, eyes move left, signifying an intact brainstem. When the eyes move with the head, it suggests significant brainstem dysfunction or damage. For example, this finding might be observed in a patient with severe brainstem injury or deep metabolic coma. Always remember that when the eyes move with the head during a doll's eye maneuver, it is an abnormal and concerning sign of brainstem impairment. Question 23. A patient with a spinal cord injury at the T4 level is admitted with neurogenic shock. Which clinical manifestation would the nurse primarily expect to observe? A. Hypertension and bradycardia. B. Hypotension and tachycardia. C. Hypotension and bradycardia. D. Hypertension and tachycardia. Answer: C. Hypotension and bradycardia. This question tests the nurse's ability to differentiate types of shock in neuro patients. The keywords spinal cord injury at the T4 level and neurogenic shock are critical. Neurogenic shock results from the loss of sympathetic nervous system innervation, leading to widespread vasodilation and an inability to compensate for blood pressure changes. This manifests as hypotension due to decreased systemic vascular resistance, and bradycardia because sympathetic input to the heart is also lost. Other types of shock present differently. For example, hypovolemic shock typically involves tachycardia. For example, a patient with a high thoracic SCI who is warm, pink, and hypotensive with a slow heart rate is likely experiencing neurogenic shock. Always remember the classic triad of neurogenic shock: hypotension, bradycardia, and peripheral vasodilation, warm, dry skin. Question 24. A patient undergoing mechanical ventilation for acute respiratory failure suddenly develops new-onset bilateral extensor posturing, decerebrate, and asymmetric pupillary response. The nurse should immediately prepare to administer which medication? A. Propofol. B. Fentanyl. C. Mannitol. D. Norepinephrine. Answer: C. Mannitol. This question requires the nurse to identify signs of acute neurological decompensation and select the appropriate immediate intervention. The keywords new-onset bilateral extensor posturing, decerebrate, and asymmetric pupillary response signify a rapid increase in intracranial pressure, ICP, with impending brain herniation. Mannitol, an osmotic diuretic, is the first-line pharmacological intervention to rapidly reduce ICP by drawing fluid from the brain tissue into the vascular space. While propofol and fentanyl are sedatives/analgesics, and norepinephrine is a vasopressor, mannitol directly addresses the immediate threat of increased ICP. For instance, in this critical scenario, an urgent bolus of mannitol would be given while simultaneously preparing for other interventions like head CT. Always remember that acute neurological deterioration with signs of herniation warrants immediate administration of osmotic therapy like mannitol. Question 25. The nurse is assessing a patient with a newly diagnosed brain tumor. The patient reports experiencing a shimmering light sensation and a strong smell of burning rubber just before having a seizure. The nurse recognizes this as what type of seizure phenomenon? A. Post-ictal phase. B. Absence seizure. C. Tonic-clonic seizure. D. Aura. Answer D. Aura. This question tests the nurse's understanding of seizure semiology, specifically the pre-seizure sensory experiences. The keywords shimmering light sensation and strong smell of burning rubber occurring just before having a seizure are classic descriptions of an aura. An aura is a focal sensory, motor, or psychic experience that precedes a seizure, often serving as a warning sign. It is considered part of the seizure itself, typically a focal onset aware seizure, which can then generalize. The post-ictal phase occurs after the seizure, and absence or tonic-clonic seizures describe the generalized seizure types themselves. For example, some individuals report a rising epigastric sensation as their aura. Always remember that an aura is a distinctive pre-seizure symptom that helps localize the seizure's origin.